All right, good morning, everybody. We'll get started with Grand Rounds today. So for those who don't know me, I'm Serene. I'm the antimicrobial stewardship pharmacist here at Children's. I'm here to introduce Dr. Erin McCreary. And so for those who don't know Erin McCreary, she's actually like a giant in infectious diseases pharmacy. So when I first accepted this job, literally the first thing that came out of my mentors' mouths were like, "Oh my God, you'll be working with Erin McCreary." And I was like, I mean, yeah, I guess like I don't know if I'll be like interacting with her that much, but I will be working with her. And then funny enough, she's my boss now. So it was like a very interesting turn of events. But she's also my mentor in life, and I'm honored to introduce her today. So Dr. Erin McCreary is a clinical assistant professor within the University of Pittsburgh Department of Medicine, the Division of Infectious Diseases, and she's also the senior of infectious diseases strategy for UPMC. She received her PharmD from the Auburn University Harrison School of Pharmacy and completed her PGY1 and PGY2 infectious diseases residencies at the University of Wisconsin Health. Dr. McCreary has led the implementation of multiple infectious diseases and antimicrobial stewardship initiatives across UPMC's 37 US-based hospitals and published numerous peer-reviewed manuscripts in these areas. She has also served as the pharmacist lead on several large randomized trials across UPMC and has been integral in design and execution of lottery systems to ethically allocate scarce healthcare resources. From 2020 to 2024, she chaired the UPMC COVID-19 Therapeutics Committee until the committee was thankfully no longer necessary. She also led the largest randomized clinical trial of monoclonal antibodies in the world here at UPMC. She's currently the president of Society of Infectious Disease Pharmacists, and actually, I believe she recently passed the baton, but she can correct me on that, and the host of Breakpoints, the SIDP podcast. Her practice and research interests include infectious diseases and antimicrobial stewardship in immunocompromised hosts, gram-negative resistance, and stewardship-related quality improvement. She's also passionate about professional leadership, mentorship, and preceptorship. So without further ado, I'll pass the stage to Dr. Erin McCreary.
Good morning, everyone. Thank you so much for the invitation. It's really an honor to be here. This hospital is much nicer than Presby, just so you can tell. I walked in, I was like, wow, it's so nice here. People are really happy here. Okay, so I'm going to share with you some work across UPMC that I'm extremely proud of. And really what we're going to focus on today is how we created a family environment amongst our antimicrobial stewardship teams, our infectious diseases providers, so our physicians and our APPs, our infection prevention colleagues, and our laboratories, which really started with a focus on the micro labs, being ID people, but has really expanded since to immunology, pathology, special chemistries, et cetera, and how we have all built this collaboration through our infectious diseases strategy collaborative, and how we're really striving to bring high value, innovative care to all of our patients across the organization. And so to take a step back a little bit from current day, the invitation to be here today was based around work I did in the pandemic, where, as Serene said, I co-chaired what we called the UPMC COVID-19 Therapeutics Committee at the time. This was an adult and pediatric collaborative environment. And I did serve as the lead US pharmacist for the REMAP CAP trial. And so the prompt for this talk and this invitation was, can you come and talk to us about the COVID work? And I was like, no one wants to hear about COVID-19. I was like, why would you ask that? But I think in talking about it, I was like, taking time to reflect back on what we went through in COVID-19 was actually a really cool experience. So I really want to thank you for prompting this and bringing us back, because what we did then has really led to where we are now, which I think is important. So as Serene said, we retired the COVID-19 Therapeutics Committee on December 27th, 2023. And we transitioned the work of evaluating preventative and treatment options for any infectious disease back into regular pharmacy and therapeutic committee infrastructures. And what really prompted that transition was there was an antiviral medication called molnupiravir that had only been available through an expanded access or an emergency use pathway. And it got FDA approval. And when it did, we were like, that was the last one. All of the COVID therapies at that point in time had full FDA approval or had been fully withdrawn. And we said, it's time to get rid of this kind of emergency response pathway that we had developed and let COVID therapies from now in the future fall into our regular infrastructures. And that was a really weird moment, because medically for me, that was when I was like, oh, the pandemic's over. Like, our work here is done, at least for now. And it I think the impact of that changed all of us in ways we'll really never fully go back from. I think we're all forever changed from what we went through from 2020 and beyond. So then I was thinking about that and how to prepare for this talk. I was trying to find the right adjectives, which is really where this slide is represented. And I kept thinking of these words and I came up with some of these. And then I realized, at the end of the day, like 2020 was weird. It was weird. That's not very elegant, but it was appropriate. And I think that's really how I felt when I was making this talk. It was weird and it was so hard. It was so hard. But 2020 gave healthcare and all of us really, I think, the paradigm changing jolt that quite frankly we needed. I don't know we'd be where we are today had we not gone through what we went through then, which is really true of many things. And not to repeat some of my bio, but I think just my journey is important to this as well. So for some additional background on my career journey, I went to pharmacy school in Auburn, Alabama, War Eagle. And then I completed 2 years of infectious diseases residency at the University of Wisconsin. And then I moved to Pittsburgh in 2018, and I took a position as a stewardship pharmacist at Presbyterian. And really, that's what I thought I was going to do for the rest of my life, was like, look at patients on antibiotics and call physicians and APPs and say, can we optimize these antibiotics? And I was really, really happy doing that. And at the time, there wasn't even a stewardship pharmacist at Children's. And while many hospitals across UPMC, we had a lot of hospitals then, less than we have now, but we had a lot. And, they had UPMC on their signage and they were purple. But really, when I came here, like no one, I definitely didn't. No one thought of the other hospitals when we were doing our work, right? We were taking care of our patients. We were maybe doing these really cool local quality projects. We were doing some research, and I gave nothing else any thought. I worked at Presby. I was important, and it was great. And then the pandemic happened, right? And in the pandemic, I think the most interesting thing in reflecting back was that none of us knew anything about COVID-19. And the medical hierarchy that is so fundamental to how we live and how we thrive, which is an important structure, but it was completely leveled. We were all the same. We were all scared. We were watching patients die at a rate that far exceeded the rate we were comfortable with. And there wasn't really a whole lot we could do about it other than try to work together and figure it out. And so we did do something about it. And so while the pandemic was horrible, when I look back on it, I see that through that, we set up ourselves to be able to do all of these amazing things across UPMC that we can do now as a system because of what we went through back then. And so for those of you, I don't know, how many of you in the audience were here in 2020, or how many worked at UPMC in 2020? Okay, about half of the people in the room. And that probably tracks because it also led to a lot of kind of change during that time. But UPMC, for those of you who may not know, during 2020 and beyond, served as the United States leading center for the REMAP-CAP trial, which REMAP-CAP was actually an ongoing global platform trial for community-acquired pneumonia. And UPMC was actually an enrolling center prior to the pandemic. And we were looking at things like Augmentin versus Ceftonir for CAP and things like that. And like, boo, Ceftonir, this is a Pete's hospital. So REMAP-CAP was a platform we were familiar with that led to then being able to rapidly enroll for the pandemic. And it's still ongoing today. Over 16,000 patients have been enrolled in this platform, 240 sites around the world. So it's an honor to be a part of this. Actually, so for our critical care colleagues, some of you may be on the line, there's a massive critical care reviews conference that happens in June right now. And they just released I think practice-changing results about oseltamivir in the ICUs and how it potentially may cause more harm for patients with CAP. So we're still learning from the REMAP-CAP trial, which is great. This was an extraordinary effort across the system. So every single patient that got admitted to a UPMC Cerner hospital, which was the majority of them back then, this was our primary EMR, had this COVID-19 intake form completed, which is the thing in the upper left corner. And this intake form asked a patient a question. So we came in and every single patient had the same questionnaire, adults, kids, everyone. And it said, what are your symptoms, et cetera, and are you interested in learning about experimental therapies? If a patient said yes, that button click then triggered an email to a centralized pool of research coordinators where teams had all contributed CRCs that sat and triaged these patients that said, yes, I want to learn. We then reached out to these patients via FaceTime to their personal cell phones, iPads. We had nurses positioned at some hospitals, but this is back when no one could go in rooms of COVID patients, right? And it was just such a creative way to reach patients that we weren't physically in front of. And this was every patient, every hospital. So you didn't have to be at a fancy academic center. Anyone could enroll in REMAP-CAP. UPMC Altoona was actually our highest enrolling hospital. And so we then built custom electronic record prescriptions for different things in the trial. And the other cool thing about this is we were using repurposed medications like hydrocortisone, azithromycin. So all of our pharmacies had them available, and we made the decision to allow dispensing of these meds from routine pharmacies to circumvent the paperwork and the burden of investigational drug services, all within the right context of the trial. And so again, everyone had access, and no matter the patient's zip code, everyone was allowed to get the same kind of care, and we worked together as a team. The other beautiful thing about Remap Cap is that we didn't allow anything outside the context of a clinical trial. And we had really robust electronic health record support to guide appropriate prescribing. So I was going back again through all my content from 2020 to 2023, and what a roller coaster this was. And this is a literal screenshot from my OneDrive. We had a whole guideline that said, these are the things you should not give to patients. And literally bleach was on there for a point in time. You can kind of see the dates. I updated this about every 5 days. We called it the COVID no meds list. And we all agreed that we were going to learn together and do the right thing, that we weren't just going to prescribe random stuff, that we were going to do this in an organized fashion. I wrote over 110 versions of the UPMC COVID-19 treatment guideline. And my CHP counterpart, so in this time, we hired a stewardship pharmacist at Children's, which was amazing. And they helped me write over 80 or so versions of the pediatric guideline. And we did it together. We updated adults and we updated peds in tandem. And the pandemic is really what connected me to children. So I met a group of friends during that time, mostly through Twitter, RIP, who I still get together with regularly. Some of them are here today. So Dr. Freeman, Dr. Nowak, et cetera. They really kept me going. So there were times we were giving grand rounds every week. Again, brought us all together, connected our hospitals and our environments. Every week we'd give grand rounds on the stuff that had been published in the past 6 days. And sometimes those talks just got really hard. And it was you guys here at Children's, you would like tweet at me. And I was like, okay, I got to keep going. I got to help these people. Had never met them in person, but you really motivated me. And it was great. Other fun things about the pandemic, patients were finding UPMC directly. These were people in the wild who would message me on Twitter and were like, can I come to UPMC for monoclonal antibody therapy? You guys are the only ones that are seemingly doing this correct. And that was honestly true. We can be very proud of that. We were reaching patients at a level that no other health system was reaching patients. We actually intentionally did Facebook marketing campaigns to get people to come get vaccinated, come get monoclonal antibodies. And then I told you guys it was weird. At one point, Microsoft Teams contacted me directly with a Beyonce reference. It was really weird, but it was awesome. Okay. The pandemic really brought us all together. Okay. Really brought us all together. You would think it would work better. There were times in 2020 we got a little bit punchy. Okay. This was November 2020. This was a pharmacist was like, this nurse is calling me. I'm like, I'm just waiting for Nevada to count these votes. We can't have it all. Okay. But we were exhausted, but we really gave it everything we had, and we pulled together like nothing I've ever seen before. So when we were launching Remap Cap at UPMC, and we said, we are only going to give these experimental meds in the context of a clinical trial, in that Dr. Angus was our chief innovation officer at the time, and he kind of coined this phrase, learning while doing. This is a really nice editorial he wrote in JAMA. And UPMC, I think, led the United States and potentially the world in promoting trial designs where we made randomization more comfortable than doing something. And we really leveraged a common platform for clinical care, trial enrollment, and data collection. And we embraced the value of reducing uncertainty around proposed therapies. And I cannot emphasize that enough. We made it valuable to both patients and providers that uncertainty is a good thing, randomization is a good thing, and that sometimes in medicine, doing nothing is providing excellent care because it helps us learn what might actually work for patients down the line. We learned that perfect cannot be the enemy of really, really, really good. And you're not going to be able to build one singular thing that supports every single patient and their unique needs, but we can get 99% of the way there and do really, really well. We leverage technology, which will be a continued theme. I know we're in the midst of this Bridges transition. I know it's hard. It's going to be painful. And the only way out is through, you guys. The only way out is through. We're going to get through it, and then it's going to be awesome, okay? And so again, we're really working together. And so with that background, I want to quickly review some of the really incredible things that came out of the pandemic to then go into what UPMC is accomplishing today. First and foremost, mRSA vaccines are one of the most impactful and life-saving scientific advances we will ever see. Hard stop. I literally have these framed on my wall. You all should too. I think looking back at the Pfizer and Moderna data is just really humbling, actually. And when you're sad or you feel like you can't progress science anymore, like look at these graphs and be like, we did this in a year thanks to the work of hundreds of millions of people that laid the groundwork for this technology and the work that you guys are continuing to do. You never know that what you're doing today, how it's going to impact what you do tomorrow. And these are just like, when I look at these, I'm like, wow, we really did it. Like vaccines really saved a whole lot of lives. UPMC was the only health system in the world that incorporated equity principles into treatment allocation, and we were transparent around those decisions. You may or may not have looked at them. It's fine if you didn't. It's only my life's work. But we had, I can't even tell you the number of physicians that email me still and are like, we have COVID guidelines. I'm like, it's fine. We have this thing called InfoNet. It's kind of like Google. Okay. So when remdesivir first came available, if you guys remember, they sent us like 46 vials of drug. Each patient needed 6 to get a treatment course, unless you were a kiddo, and then you got less because it was mgs per K. And so we did not have enough drug to treat every patient in the hospital that had COVID. We also didn't know if the drug worked. So we were trying to figure out which patient would benefit the most from a therapy where we really don't even have that much information. So what we did is we implemented a lottery system where people would not refer patients to us, but rather every single patient would get an equal chance. Because when you do a self-selection referral system, it's kind of inherently biased to people that are more educated or have more resources. So every single patient that had COVID, I, for 6 months, woke up every morning at 4 a.m. and ran a list of every single patient admitted to any UPMC hospital with COVID. We then reviewed their charts and saw if they were clinically eligible for remdesivir therapy. They then got entered into like a computer generator lottery system where they would get allocated or not allocated medication. And those that were allocated medication, we'd call their primary physician directly to speak to the patient about whether or not they wanted to accept this experimental therapy. If the patient accepted, we would ship them 6 vials of drug allocated to that particular patient. And if they declined, that allocation went back into the lottery. We shared. And our hospitals were so amazing and so creative beyond what I had even thought of. I had nurses calling me like, this patient discharged, they got better. I have 3 vials left. I'm sending them back to you so that we can share them. They weren't like hoarding. And it was really just this really phenomenal process. And that led us into what we did with monoclonal antibodies. This was actually Evusheld, which was a preventative antibody for immunocompromised patients. When Evusheld came out, it had significantly reduced the likelihood that an immunocompromised patient would get COVID. It was very impactful. We had immunocompromised patients telling us that this drug changed their entire life, that they hadn't left their house in over a year because they were so afraid of contracting COVID. And this kind of antibody protection made them feel like they could go to like their niece's birthday party or these kinds of things. But when Evusheld came out, I think we were sent a couple hundred doses and we had over 100,000 patients across our infrastructure that would have been eligible. So not only did we run reports with coding of who has diseases that would make them Evusheld eligible, but we actually reached out to special interest groups. So here at Children's, especially some of your allergy, immunology folks, pediatric patients with very rare genetic disorders, we wanted to make sure we had all these patients on these lists. And then we weighted this allocation system based on their likelihood to get COVID-19. So not everyone with an immunocompromising condition is created equal. First, we stratified them by how immunocompromised. And we had a team of about 20 clinical stakeholders that said, these people are the most profoundly immunocompromised, and then these patients, and then these patients. And we went with the most profoundly immunocompromised first. And then we looked at what is their likelihood to get COVID-19. And we knew by this point in the pandemic, if you lived in an area that had a very high area of deprivation index score, meaning you're in more crowded conditions, you're more likely to have to go to daycare, you're more likely to be in a job where you have to work around people all the time and get exposed. Those patients, so this lottery did not give people an advantage over the other. It made people who started in this world extremely disadvantaged on the same playing field as those who didn't. And we were successful in this, in that patients that were more likely to get COVID-19 were more likely to receive drug. But interestingly, we found that Black patients that were offered drug were less likely to accept it than white patients. And so even in that, we learned we had so much further to go in actually reaching our patients. And again, laying the foundation for future work. So all of this, along with the remap cap infrastructure, led us to launching that was prevention. On the treatment side, we launched the largest monoclonal antibody randomized trial in the world in November of 2020. I think this was successful because we made doing the right thing easy. So I knew that prescribers were never going to be able to order the complex drug names of monoclonal antibodies, with all due respect. At one point in time, there were 4 different ones on the market. I could barely pronounce them. They changed all the time, and the availability was always nebulous because they'd ship us some from Lilly, then they'd ship us some from GSK, and it was like, how are we going to do this if you're ordering the actual drug? So this trial was actually not designed out of a desire to do research, but out of necessity. And so I said, you know what? You're just going to order monoclonal antibody treatment. At this point in time, we definitely have equipoise to say we're pretty sure they're all the same. We're going to consent patients to all of them. We're going to say, you're authorizing yourself to get treatment. You might get one of these 3 or 4 drugs. We will tell you which drug you get, but we do not know at this point in time because we had to move so quickly. You ideally wanted to get antibodies into patients within the first 48 hours. So prescribers wrote a central referral that went to a centralized team who then made a paper order for the actual drug. And pharmacists, and this was cool, it was any pharmacist in the whole system. You didn't have to be special. You didn't have to have advanced training. Any pharmacist, when they got the antibody order, they took the patient's MRN, they put it into an app we developed with clinical analytics that randomized the patient to treatment based on the local inventory at that site. So whatever that site had, the patient got. And then we made a real order, and inadvertently, we had the largest randomized trial of monoclonal antibody therapy in the world. We treated 26,769 patients over 2 years. In September of 2021, when the Delta surge hit, we actually ran out of infusion chairs. We had on Labor Day weekend that year, we had over 1,000 monoclonal antibody referrals and only 400 chairs in the system. And so I said, okay, we're going to give them subcutaneously. we're going to take a 3-hour chair block for an IV infusion, and we're going to change it to a subcutaneous push so I can fit 4 patients in one slot. And I'm just really lucky that I had a lot of people that were like, that sounds great, and believed in kind of that science. And we knew this was probably okay. The EUA said you could give it subcutaneously if IV wasn't available. And I said, something's going to be better than nothing in this situation, and we're going to study it. So we published the only data of sub-Q versus IV, which has since changed the paradigm for how drug companies develop immunotherapies, prioritizing sub-Q and IM injections over IV because we don't have nurses that can place IVs in outpatient centers, right? And so it really has changed how AstraZeneca and all the J&J, all these other companies are bringing immunotherapies to life moving forward. We treated over 1,000 pregnant persons, the most of anywhere in the world, with monoclonal antibodies. And again, none of this would have been possible if we hadn't worked together as a team. So I wrote this reflection piece in CID about the monoclonal antibody experience. And I think it's really important to live from our learned experiences. And I also want to be really humble and honest that sometimes we make bad decisions. And I almost made a very bad decision when it came to monoclonal antibodies, because when this first came up, I tried to punt it. These are my direct words. These are from emails I sent. I was like, I think outpatient coordination is beyond us being the COVID therapeutics committee and the work I was leading. This was predominantly an inpatient group at that point in time. And quite frankly, it just seemed too big to be real. Like, I was so tired in November of 2020. And I was so overwhelmed. And I was like, how are we going to bring patients who have COVID-19 in a world that does not have a vaccine into outpatient infusion centers where we treat people with cancer to get IV therapy when I don't even have enough nurses to staff inpatient beds? Like, it just seemed so daunting. And I think it was an important lesson in science and clinical practice in that, you know, we're so interested in the clinical care piece, but if you can't operationalize it, you could discover the most life-changing thing in the whole world. And if you can't actually get it to patients, it doesn't matter. And so this was really a time where we had potentially, it turned out to be life-saving technology in monoclonal antibodies. And if we couldn't get it to the patients, it didn't matter. And getting it to patients in this setting seemed just impossible. Once we had a vaccine, it was different, right? Like, once we knew we could protect people, it was a little easier. But in November 2020, it was really hard. But also fun that came out of this. So luckily, like, basically everyone I worked with was like, get over they gave me like 2 hours to whine. And then they're like, okay, so now you can do it. And I did it. But so one of the physicians I worked with actually he's like, okay, you sound like you need some help. He's like, I know a guy, I'll connect you to this administrator who runs the UPMC urgent cares and emergency departments. So he sent an email that said, hey, meet Erin, meet this administrator guy. Let's start to talk logistics, because this was really where operations came into place. And I sent him an email. I said, do you know what you're getting yourself into? And he's like, I'm happy to help. This is now my life partner. We've been together for 4 years. So life comes at you fast. So with that, let's talk about today. So let's talk about the ID Strategy Collaborative and the work we do. A lot of the work I do is based in this quote. It's kind of cheesy, but my boss shared this with me. I really like it. So if you want to go fast, go alone. And if you want to go far, you go together. The other thing that kind of guides our work is that better has no limit. I think we've done a lot of good, and we can really always be better. And that's not in a sense of like, oh, I'm never going to achieve things. It's that with an infrastructure as large as UPMC, with the brilliance that's in this room and beyond, really better has no limit. And I think this is how we frame things. And I think I want you guys to kind of see what I see now in a little bit, where you're the large flagship hospital, right? That's where the lens I was coming from. I'd always worked at large academic medical centers. And it's really hard for us to think about a hospital that has 40 beds in the middle of nowhere that doesn't even have a 24-hour pharmacy in their hospital, not to mention in their community, right? So when a 6-year-old comes to the ED at 9 p.m. and maybe needs antibiotics, they can't do a mg per kg dose because no one's there to compound it, and there is no pharmacy, and we can't just give them a script because there's also no pharmacy. And so like, what do we do in that setting? And so we've actually recently, this is a real problem we just tackled in the strategy collaborative. So we came up with a process where we're going to give away, UPMC is going to eat the cost and give entire bottles of antibiotic suspensions at some of our sites when the pharmacy closes at 5. And we built a special order for them to be able to dispense these things when you're not able to do a unit-based dose for a kid. Right? I think that's really valuable care, but admittedly, I would have never thought of that as a problem until I started this work. And then on the flip, for our smaller hospitals, they know every single human that walks in and out of that building. Every single one. Okay. They have a total of maybe 100 employees sometimes. Every single person is their friend. They cherish these communities. They're from these communities. They are so used to being so nimble in decision-making because they had to ask like 4 people to do a monumental thing. And now we're like, actually, can you talk to 37 other hospitals before you make a decision? And so on both ends, this work requires us to kind of appreciate where the other is coming from. So I'm a very big believer in this Donna Beaton model. You may or may not have heard of it. But I think it was developed specifically to assess quality of care in clinical practice, and it focuses on structure, process, outcomes. So structure is every factor that affects the context in which we deliver care to patients. It is the physical facility. It is this beautiful room we're sitting in. It is equipment. It is you, the humans that do this work. It's how you train staff. It's how you get paid. Like biweekly versus monthly, does that impact how you provide care? Maybe. So structure is almost always the upstream cause of any problem. So when you're like frustrated because you can't do something, or you think this order set's broken or whatever, it's always almost a structure problem. And that's really where we focus our efforts. Because if you have a good infrastructure, it drives the rest. So then process is the sum of everything that makes up healthcare. It's how you make a diagnosis. It's how your patients ask you questions. It's how they interact with their family members, education. Process is treatment, prevention. It's how we deliver care. And then outcome, of course, is the effect on healthcare and on the population at large. This model does not have an implicit definition of what a good outcome is. We get to define that, but it just tells us how we get to outcomes in general. So in the middle of the pandemic, around 2022, I reflected on this and I was like, I have like unofficially, again, at this time, I'm like a stewardship pharmacist at Presby. That was my technical job. I'm like, we have been doing this system level work for years and it works. We have one order set. Everyone has access to the same treatments. We have one guidance document that everyone can follow. We have a uniformed approach to testing in our laboratories. All of our infection prevention and control teams across every hospital follow the same algorithms, and we're doing really good things. And we're generating data and we're taking really good care of patients. Maybe we should do that for every other infection. And I was like, what is next? How do we translate this work? And I'm like, so what do we do? Like, do we just go back to the way things were before? Like, I was like, do I even remember how to treat a skin and soft tissue infection? Like, are people still getting osteo? I have no idea. Like, I'd only done COVID for so long. But I was like, eventually I think people get other infections still, and they might come back to the hospital. And so I wrote my job description to say, can I just what I've been doing for 2.5 years, can that just be my job? And luckily enough, the executives in our organization were like, that sounds fine. You can keep doing what you're doing. I was like, yay. So I moved into an official system job in 2022, in the summer of 2022. And we created what we first called the ID quality team in July of 2023. We have since renamed it to the Strategy Collaborative because from a system quality perspective, we now have what we call a quality committee or a QOI for every hospital acquired infection. Some of you may be on those committees, and we just didn't want the confusion with the word quality. But if those of you have been around since before 2022, ID quality and ID strategy collab are indeed the same committee. We just went through a little bit of a rebrand. But again, this brings together labs, infection prevention, stewardship, clinical ID to try to do good work together and try to support you. When we did this in July 2023, we blew up everything. I was like, we are going to cancel every meeting on everyone's calendars. And we did. I was like, just stop. For 2 months, I'm like, we're just going to do nothing. And we're going to think really critically about like, where does work get done? Who needs to be at the table for these conversations? And then what is the best cadence and what is the best use of people's time? Time is our most valuable resource. Where you put your attention is our most valuable resource as humans. And it's the only thing we're never getting back. So like, I think it's so important if you're in a meeting, the meeting should have a purpose. And if it doesn't, hang up, cancel it. If you don't know why you're on the meeting, don't be on the meeting. Okay. So I think that's really important. I think that's kind of like when we think about systemness and we get like tired of it, I think that's probably where we like burn ourselves, is because we're just having all these meetings and they may or may not have a purpose. So in the interest of time, I'm not going to go through this, but this was kind of our structure. We were very transparent. We actually held town halls in early 2024 across the whole system to say, this is where your ID people are going to be and when. Here's the days of the meetings. Here's who attends them. And then we created these work streams. Again, if you're going to have a meeting, make sure it has a purpose, make sure it's worth people's times. So we clearly defined what the meeting is, who runs the meeting, and what the deliverables are from the meeting. And again, I know this is kind of like boring admin stuff, but now I get emails, phone calls all day, every day. A good friend and colleague here at Children's in Critical Care texted me like a month ago about CSF testing for children. And I said, I got you. I know exactly where that starts. And so every idea is honored. Everything goes on an agenda, but I know where to put it based on the areas of focus and who needs to be at that conversation. And with this structure, we have been very successful in the last 2 years and have churned out a lot of really good output for patients. We are also transparent, which I cannot underscore enough is so important. I don't think people really mind the work you do, but they just want to know what the heck is going on. And so everyone in our stewardship collaborative, in our ID strategy collaborative, can see, we call this the project tracker. I know I'm very creative. It is a project tracker. I couldn't think of a more fun name for it. But anyone in the system at any time can submit this agenda request form that says, hey, I have this idea in the ID space. I hate how we treat PJI. We need more CSF testing. I hate how we order tick disease. I love this community-acquired pneumonia thing. Can we do this for other stuff? And you can submit the idea, and then we put it on the project tracker, and I say, where is it going to start? Who's responsible for it? And where's it going to go? And then anyone can look at this at any time, and we have updates and you can see where the work is. And I think this has really helped our family culture and our buy-in. I'm going to skip over some of this in the interest of time, but this infrastructure led us in 2025 to be able to set goals for our hospital-based pharmacists. So traditionally, all of the stewardship pharmacists in the system report up through their local pharmacy department. And honestly, their goals were like kind of these generic pharmacy department goals. And it's like, you can't be successful if you don't know what success looks like. And if your job is antimicrobial stewardship pharmacist, your goals should be tied to antibiotic usage. And so I feel very fortunate that all the pharmacy directors in the system and our system pharmacy leadership have let myself and my partner, Tina Kadem, set the goals for the local pharmacists. It's kind of how Serene ended up coming to report to me. So I was like, she's awesome. I'm going to snatch her up. And when we set these goals as a system, we saw a 5% decrease year over year in antibiotic use. And 5% may seem small, but we have had pretty robust antimicrobial stewardship at most of our UPMC sites since it became a Joint Commission requirement in 2017. And so when you're already like patients need antibiotics, you can never get to zero, right? There's always going to be patients that come to the hospital that genuinely need antibiotics. So you cannot get to a point where this is nothing. And so when you have successful stewardship programs, the best you can hope for year over year is maintenance. And so the fact that we've been doing really good for 10 years and continue to see a 5% decrease is like really tremendous and actually speaks so much to the relationships we're forming and the diagnostic technologies we're implementing. So let's talk about children's and how awesome Dr. Catherine Hayes and Dr. Serene are. So Serene pulled this for me. So if I screw it up, I'm sorry. Okay, so this is the Pediatric Health Information System, or FIDS. And these data are compiled by the Children's Hospital Association. In 2024, before Serene started here, Children's was the #1 user of antibiotics in the country. I love you guys very dearly. This is not a time you want to be #1. This is a bad #1. Okay. This is not great. Not so good. Okay. So Serene started in October of 2024, and by the end of 2025, you're now ranked 8th, which is excellent, actually. And it is a 17% decrease in antibiotic consumption in 1 year. That is insane. And so I want to thank you all for supporting them and this work. And just, this is really tremendous. They set goals. A lot of these goals are around education and tracking, but really one of their goals is handshake stewardship in the PICU. Handshake stewardship is the coolest thing stewardship programs do. It's pervasive across the globe now, and it started in Children's. So it started at Children's Hospital of Colorado, October 2010, long before a lot of people even knew what antibiotic stewardship was, long before we had randomized clinical trials supporting shorter durations of therapy, and long before we had a lot of the rapid diagnostic technologies we have now. So with really very little awareness of why this was important and very few tools in the toolbox to help support decreasing antibiotic use, Amanda Hurst, who's a pharmacist, and her physician partner, Sarah Parker, said, you know what, we're just going to go round. We're going to make antibiotic stewardship a consult service, and we're going to go hang out on the floors with all the teams, and we're going to talk about every patient that's on antibiotics, and we're going to make collaborative decisions together. And they dropped antibiotic use by 11% in their first year, again, with really no tools other than being friends. And so this handshake steward, and they wrote this paper, they called it handshake stewardship. That term has stuck. Started in peds, spread everywhere. It's fantastic. Quickly, you could just continue to see how Children's is crushing it. Serene pulled me these last night. So again, thank you. When we do antibiotic use, the National Healthcare Safety Network asks us to report it in days of therapy, where 1 dose of one drug on 1 day is a day. So if you come to the ED and you get 1 dose of ceftriaxone, that counts as a day, okay? If you get ceftriaxone flagyl, that's 2 days. So 1 dose, 1 day. And then we normalize it to 1,000 patient days, which is like bedded patient days. And you can just see these continued downward trends. This is your vancomycin use, echinocandins, and cefepime. This is really just incredible work. So I just want to thank you all for leaning into this. And yeah, clap for you guys. And with my last 10 minutes here, I'm going to talk about some really cool things UPMC has done system-wide through the ID Strategy Collaborative to bring better tools to take care of adult and pediatric patients. So the first is the expansion of blood culture rapid diagnostics. So at Children's, you guys actually did have this technology already. So when we started this initiative 2 years ago, 14 of the 37 UPMC hospitals had access to this technology, either via an ePlex system or a BioFire blood culture identification system. So you guys had it, but all the kids you get did not. So you had patients coming from all across the enterprise or even outside UPMC, positive blood cultures, and you had to wait 2 days to understand what was going on with them. That sucks for the kid and it sucks for you, right? It also, when patients would come to the emergency department, have likely contamination and discharge, and sometimes these kids live 2, 3, 4, 5 hours away. We weren't running these on discharge cultures because we were like, it's not worth it, they discharge. But we found if we would run this technology and get the organism identification within 2 hours of that blood culture turning positive, we could prevent so many kids from having to come back. Because you knew while they were still dry, they're not even home yet, and you already knew that it was coag-negative staph, and you didn't have to call them back, which has been really life-changing for some of these patients. So we started this journey 2 years ago. This was like my passion project. I was like, we have to bring rapid diagnostics to every hospital. And I will tell you, we had very strong system support for this. This was a $3 million investment across the enterprise. And it was not about the money. It was about the operations. It was about where is the physical space to put a machine in the lab. And my lab people are like, thank you. One lab was like, I don't know if I have another outlet. Like I might need an electrician to come. This is the kind of stuff we're talking about. It was about, we need to interface these machines with Bridges, and we've already roadmapped every machine for Bridges, so now we got to redo it. It's about all of those interfaces have an associated cost. And then most importantly, tests don't work if no one uses them. And so the test result in the chart doesn't mean anything if a provider isn't going to act on it. So on our end, we had to say, how are we going to communicate these results in real time, who's going to receive them at all of our different sites? How are we going to communicate if patients transfer? And then what tools are we going to give physicians, pharmacists, and APPs to respond to this test? So that was really the work. We installed 8 new machines. We actually shifted blood incubation from 11 smaller hospitals to 5 regional hubs. And we committed to the fact that this had to be rapid. So I think when you read about regionalization and systemization, where people are like, oh, it's terrible, is they might centralize to a big lab, but they might only, pick up the blood bottles once or twice a day. We said that's unacceptable. We're happy to centralize, but we need to ensure this is still rapid. So we have invested a lot of time and money into a massive courier infrastructure where we are running couriers no more than every 2 hours. So usually every hour, but sometimes every 2, to pick up these bottles and ensure this is still rapid, even if you're a community site. We have decreased length of stay by 2 days in patients with positive blood cultures. You can kind of see the drop in length of stay after you adopt blood culture diagnostic technology. And just because I do want to honor that there's a lot of length of stay work going on across the system, and I don't know that, again, I can't take full credit, but in hospitals that did not adopt this technology yet, we have like 4 or 5 to go, and we ran these data before we'd implemented in about half. Really not moving the needle on length of stay compared to for patients with bacteremia only, right? Control what we can control, but this has been unbelievably impactful. MRSA PCRs are another diagnostic tool that tells a really good team story. So this was pre-MRSA PCR implementation at some of our sites. Again, at Children's, you had MRSA PCRs, a rapid test to tell if you have nasal colonization of MRSA. You had that for some things, but not all things. So some of your NICU screenings and whatnot are still done on Augur. It takes a couple of days. And what we had was this mess. So this is adult Cerner, but it's just kind of like a mess, right? You type in MRSA and you're like if you're a provider, like which one do you order, right? It's like, that doesn't help me. So this is the work I do, is try to be like, I want you to have one thing to click. That's the goal for everything. So MRSA, you should have one thing. And these are actual Teams chats of like, what the heck are we doing? And for patients, we had sometimes like multiple tests, right? Because you'd have an Augur pending from infection prevention and you'd have a PCR ordered, and it was like kind of chaotic. So we're like, let's work together. So about a year ago, we said, okay, from an antibiotic stewardship clinical care perspective, I want access to PCR technology everywhere, every patient, so that if I'm starting anti-MRSA therapy, I know within 4 to 5 hours if I can stop it. And in stable patients, even better, I can just hold it because I can just send the screen, and if it's negative, I never even have to start it, right? The negative predictive value is very high. But from an antibiotic perspective, we had to commit to judicious use. I can't be sending an MRSA PCR for a UTI. Like, MRSA is not a UTI pathogen most of the time. And if my prevalence of disease is 0, then my negative predictive value is going to be 100%, but I didn't need a test to tell me that, right? And so we had to empower our clinicians to think and to not send tests when you already know the answer, and only send the test when it's really going to help you make a good decision. So that was our commitment from a stewardship perspective. We're going to hone in on pneumonia because that's really the bang for the buck with this testing. But we were like, we know the PCRs cost way more money than the Augur. And so we were concerned that, we may or may not be able to do this. But then we talked to our lab friends, and the lab was like, oh my God, please help us get rid of Augur. They're like, Augur is time consuming. It takes up all this space on the bench. The techs don't like it. We get all these phone calls because y'all have all these multiple tests running, and you're calling us to be like, which one, cancel one. It was like operationally a nightmare for the lab. And really, by streamlining to PCR, the actual tests cost a little bit more, but overall lab operations have a tremendous gain, and you get more tech time, which is more valuable than anything. And we run MRSA PCRs on the same machine we run C. diff and a bunch of other tests, so there wasn't a capital investment required, which is always helpful. And so the lab was like, we would love to go to PCR, but you guys have to stop sending so many MRSA screens. And we were like, we've already committed on the stewardship end, so what's the problem? And the problem was our friends in infection prevention. And they came to the table and they were like, yeah, we've been meaning to tackle this. They're like, some of our hospitals screen every single patient who comes through the door every time, no matter what. And every week they rescreen them and all this stuff, right? And we were doing all this MRSA screening for infection prevention. And infection prevention's like, we've been wanting to tackle this. We just haven't yet. So great, let's all work together. With Bridges, our infection prevention colleagues, who are wonderful, committed to 3 patient populations that get screening: NICU babies, nursing home admissions, and patients on dialysis. That's it. No one else is going to get an MRSA screen when we go to Bridges. And Bridges was built to support you in that decision-making. So you don't have to order them anymore. And we're going to cut those volumes way down. And so some of our hospitals have already made this transition. Children's has not fully yet. You guys are still doing auger for some patients, but by the time you go up on bridges, we will be auger-free UPMC. I made coffee mugs, t-shirts. This is excellent. This is good patient care. And you know who's really happy that we didn't even think of in this? The surgeons. And it's like, this is where the collateral benefit happens when you work together, because surgical screening is usually done by auger outpatient. We don't really think about it because we're like, they're planned surgeries, you have time. But really, it's so much more efficient and effective if you can tell the patient right then, okay, you're going to need another antibiotic. Or for urgent emergent surgeries, we were failing to screen. So we were just giving everyone Vanco, right? And so now we fixed that problem too, which is really just kind of a fantastic thing. Okay, in my last 5 minutes here, I'm going to talk about procalcitonin. I know timing's terrible. All right, let's talk about procal. And this is where you can throw things at me. So procalcitonin, I admit, when I started my career, I loved procal. In 2010, actually in 2007, procalcitonin was an awesome test. It had its moment in the sun. I'm not going to say it was never good. In procalcitonin and all the data that support the use of procalcitonin to stop antibiotics show that we took antibiotic exposures from like 14 days to like 10 days and then 10 days to 8 days. And this was great. Now in 2026, we have so many RCTs, so much. It's amazing. When I was in residency, we always used to be like, we wish we were cardiology. They have all their trials. ID has so many trials now. And so we have robust data to say you can use no days, 3 days, 5 days, 7 days for most things. And so because we are using such shorter courses of antibiotics anyway, sending these procals is no longer shortening durations of therapy. And we have always universally accepted, even in 2005, that you shouldn't use a procal alone to say whether you should start antibiotics. If a patient is sick, start antibiotics. The problem is not starting them, it's stopping them. So we looked at procal and we looked at some opportunities, and this really came up because people were trending procals, and we actually anecdotally felt that procals were causing more antibiotic use because we felt we were ignoring them when they were negative, and that when they were positive, we were treating if they maybe weren't infected. Then the Mayo Clinic published a massive study across their entire enterprise that proved this, that said procal-guided patients actually get more antibiotics with no change in clinical outcomes. And so then we looked at the data, and we were spending over $1 million a year at UPMC on procal, probably more. That's actually, because that's only the data of like patients we can see in our labs. This doesn't account really for sendouts or things we're billing directly to patients. And so it was wild. So we performed over a year in our strategy collaborative, a massive review of all the procal data. We included adults and pediatrics. We worked with the lab. And I will say, this is when Megan actually sent this to me with Dr. Freeman. So she sent me this paper, like, this is you told me the coolest things. Because I was always like, but it does help us distinguish virus versus bacteria. And if we can only just teach people how to use it better, it can still be helpful. And Megan was like, no, it's not, Erin. I study viruses. And actually, people with viral infections have really high procals or low procals, and people with bacteria have high or low procals, and actually it doesn't help. So this is a really beautiful pediatric paper that kind of guided this too. And then we looked. So our highest user of procalcitonin was y'all. Love y'all. I can't see your Cerner, so that was hard to do chart review. But I did a chart with myself and a friend. We looked at over 700 charts, and we pulled the 4 highest using adult hospitals. We matched their procals with their antibiotics because we wanted to provide you with your own data, right? And so we looked, if it was negative, did they not get antibiotics? Positive, they got antibiotics, and then the discordance. And the people we really care about are, it was negative and they didn't get antibiotics, because that's seemingly the holy grail. And when you look just at high level, it seems like a quarter of the patients that worked in. So actually we were like, oh, maybe we are following procal. Maybe it's helpful. Well, then we dug into the charts and we read their charts. We said, okay, you had a negative procal. Did that impact your decision to stop antibiotics? 179 charts. It impacted the decision to stop antibiotics in 6 patients at UPMC, 6, 3%. Then we went into the charts of those 6 patients, and of those, 5 of the 6 were never started on antibiotics, but we gave them credit to say the procal influenced their decision because they did put in the note, like, Procal's negative, so I'll continue to hold. Like they acknowledged the procalcitonin, so we counted it. But in 5 of the 6, they had already stopped. They had already withheld antibiotics. And so really what we use these data on the adult side, and we met with these providers and we said, you're really smart. Like this procalcitonin is not supporting your clinical decision-making. The only patient in the whole system where it was beneficial was a really complex cellulitis mimic, which is not even an indication where we typically think of it, but it did kind of help rule out in that setting. So I am not saying it's not ever useful. There are probably extremely niche cases where this is a useful test, but Procal at the end of the day should not be the be all end all of antibiotic decision making. And then people always point me to the ADAPT sepsis trial, which came out. This was an adult trial, but it was a large critical care trial looking at Procal, and they said that Procal significantly reduced antibiotic exposure from 10.7 days to 9.8 days. I think a couple things here. One, that's still 3 too many days of antibiotics. Okay. You either need 7 or less, or you have a legitimate infection where you need 6 weeks, right? Like there's very few in between. Some pneumonia where you're going to go for 10 to 14 days because they're not clinically improving. But at that point in time, you've decided they have pneumonia and they're not clinically well. So you're not just going to stop just because their Procal's negative. The other thing, I point you to my favorite table, table 29. The best things are always in the supplements. I will say this again and again and again. I love supplemental data. So in table 29, it shows you how this trial actually worked. And so if the Procal was negative, a pharmacist put a note in the chart that said, we strongly suggest you stop antibiotics, okay? That note went in the chart on average on day 3.5. Antibiotics were stopped on average on day 7. So this table tells me that no one listens to the procalcitonin, right? So even though this was statistically significant, I think this is a situation where it was statistically significant, but potentially not clinically relevant. And when you really dig into the ADAPT sepsis data, it shows us what we know is that your clinical gestalt is going to trump this Procal value every time, and you're not going to listen to it. So really that kind of led to us removing procalcitonin across the enterprise, except in hot babies. So that is a clinically valid reason to send a Procal. That is very widely vetted by AAP. We 100% support that pathway. And so actually the benefit of this is we removed Procal from all adults and really patients over the age of 90 days. And our hospitals that do admit and see patients under the age of 90 days, we ensured that they had Procal on site, which most of them did not. And so Horizon and some of our central Pennsylvania smaller hospitals that treat babies, they did not have on-site access to Procal. They were sending it out from the EDs and getting the result like 4 days later. So we brought in-house testing to the patients where it mattered the most, which are these babies, and we removed it from the patients where it really wasn't helping and arguably causing harm. After we went live in September of 2025, a month later, by historic data, we should have sent almost 3,500 Procals, and we sent 15 in the whole system. And I think we're doing okay. It's been almost a year, but if you still hate me, it's fine. I'm happy. I can take it. We can have the conversation around Procal. I had a few other things I was going to talk about, but I'll gloss over them in the interest of time. High level, when you guys go live on Bridges, you are going to have in-house carbapenemase testing. You will automatically get a carbapenemase test on all clinical cultures that are Enterobacterialis, that are ertapenem or meropenem resistant. That's going to be incredible. These are what these cultures look like in the absence of this. With no genetic testing, we used to have to wait days and days and days. These are real emails. We used to have to move roommates and all kinds of stuff. So the carbapenemase testing is phenomenal. We have a system infrastructure for Carba5. This has myself, some of our gram-negative researchers on the Pitt end who are collecting the isolates. We're doing a system-wide epidemiological study here for metallo-beta-lactamases, and we provide real-time support to the hospital's IP&C and their clinical leaders. So you guys are going to go up on this as soon as we're live on Epic. Right now, you send this test to CLB, so you do have access to this test right now. It's just not done automatically, and there's like that delay to send to CLB, but we're bringing this in-house for you, which is a huge win. Some tick work is ongoing. I want to thank Dr. Hannah Krieger, Dr. Sarah Wheeler, Colleen O'Hare from the labs, Andrea Kaczynski from labs, and all of our IT people. In Bridges, I'm just going to be real honest with you right now, tick-borne testing is a little bit of a cluster. We're fixing it. We're doing really good work. We're going to move UPMC from Western blots to modified 2-tier. Yay, okay. If you're going to miss your bands, I'm sorry. You can talk to me about it. It's a better test. We're going to try really hard. It's a complex lab developed test. We're going to try to explore if we can get faster turnaround times for anaplasma. We're trying to bring you things that are helpful. We realized with the EPIC Foundation that the Babesia smear was this like blood parasite malaria smear. That's like what they wanted you to order for Babesia. It required you to put a travel history, and people were like, Pennsylvania? So we're like, is this gonna, some people put Narnia? So we were like, oh man. So these are the kinds of things we're going to learn together, right? I didn't know that this is like not something you can think to test in a million years. So we had a case at Altoona actually in a pediatric patient where they tried to order a Babesia smear. They were like all kinds of confused. We have since fixed this. Babesia ordering is incredibly enhanced. We removed this travel screen. It's improved. And so I guess I'm here to tell you, like, we know the Bridges is not going to be perfect, but it's pretty damn good. We did a pretty good job, you guys. And if you see something when you go to order something in Epic and you're like, what is this? Just email me, email the ID Strategy Club, talk to your lab leaders who will bring it to the Strategy Club. We will fix it eventually, right? We're going to prioritize it and rank it, and we will tackle it together. And everyone's going to have input. A lot of thought went into these decisions. And again, what works for Children's has to work for Horizon, has to work for Altoona, has to work for Harrisburg. Last little thing, we do have in-house linezolid TDM. It's done at CLB, but you guys get results within a day. Linezolid is a very unique antibiotic, and essentially what we've learned is that the package insert was like give 600 BID to everybody, and we've learned that that's probably not true. Patients actually have crazy kinds of exposures, especially kids. It's about a third. So about 1/3 are subtherapeutic, about a third achieve dosing on package insert dosing, and about a third the dose is way too high. So Serene's all over this. Patients that are started on linezolid that kind of have high risk of sub or supratherapeutic exposures, we can do in-house therapeutic drug monitoring, and it's really freaking cool. So look at this. So the toxicity of linezolid is you get thrombocytopenia. Having renal dysfunction is a risk factor for that. So this is an adult, but you can see their serum creatinine was sky high. They had AKI. Their platelets were non-existent, and their linezolid was sky high. As we normalized their linezolid concentration, their platelets went back up and their creatinine improved. So it's really actually quite neat. And this is another thing the Strategy Collaborative has brought. The lab was so supportive of in-house testing. We are able to safely maintain patients on oral linezolid now rather than switching them to crazy drugs. So this has been a really cool effort too. We do have a system guideline on this on that InfoNet thing I talked about. Check it out. It's neat. Being a pediatric patient is criteria enough for TDM because your kinetics are so variable. And with that, again, I can't emphasize enough thank you. And if you have any ideas, we want to hear about them, okay? We really want to know.